You're listening to This Week in Cardiology from theheart.org on Medscape.
You can now access the latest in medical news on your Amazon Alexa-enabled device. Join me, Perry Wilson, every weekday morning for Medscape Medical Minute, where I highlight the top medical stories of the day. To add Medscape Medical Minute to your flash briefing, search for Medscape Medical Minute on Amazon and click Enable. Or open the Amazon Alexa app, go to Skills, search for Medscape Medical Minute, and click Enable. Then say, Alexa, what's the news? Or Alexa, what's my flash briefing? I hope you'll join us.
Hi everyone, this is John Mandrola from theheart.org Medscape Cardiology, and this is This Week in Cardiology for July 31st, 2020. This week, COVID, cardiac effects of COVID, AF ablation safety, SGLT2 inhibition, and a brief announcement. First, our brief COVID update. Yesterday, we had 4.6 million cases in the U.S. U.S. deaths a week ago were 147,000, and this week are 155,000. The rate of rise now is 1.05x, which is slightly up from last week at 1.04x. Now, some super quick thoughts on COVID. I went over to the Johns Hopkins site and looked. Florida, California, Texas have all seen spikes in cases, but it's now 4 weeks on from the spike and there's very little change in death rates there. Very little. Also, from that same data set, I looked at the cases from the 4 surging states here in the U.S., Florida, Arizona, Texas, California, and then looked over at death per 1 million. Arizona was highest at 500 deaths per million. But here's the thing, New Jersey, New York, Massachusetts all had deaths per million at well over 1,000. New Jersey at nearly 1,800 people per million. I read this week that internationally Spain, France, Germany, and especially hunker-down, law-abiding Australia are seeing rising cases. Australia, for instance, has had an 11-fold rise. Now these data points bring me back to the words of Professor Hendrik Streeck of the University of Bonn, who said in early May, quote, I am convinced that we are not going to get rid of SARS-CoV-2. It is going to become an endemic virus, which means it's going to live in our population, and we have to start living with it and find measures so that people are not dying, but at the same time we can achieve normality. Now, barring a major breakthrough in vaccines, which as I said last week, I am optimistically hopeful for, the professor's words bear huge on these new societal decisions that we must take, like getting kids back in schools. Now, the case discoveries will continue to increase as we test more and we allow people to be increasingly human again. The key here will not be total safety. Remember, safety is not binary. There's not safe and unsafe. The goal will be the best safety we can manage given the trade-offs. My colleague Eric Topol is tweeting a lot about home testing. This to me seems like a hugely effective way to help slow the spread of this virus. Now, it will have to be on sputum because young kids and even adults are not going to easily submit to these repeated nasal swabs. I had 2 last week and they are completely, utterly unpleasant. Second topic today, COVID cardiac effects. Now, JAMA Cardiology published a highly circulated study looking at cardiac involvement of the heart in COVID. The headline of the paper and the news coverage was quite scary. This is a group from the University of Frankfurt in Germany. They presented a cohort study of 100 patients recovered from COVID who underwent CMR. CMR, of course, is cardiac magnetic resonance imaging. They had these scans at weeks to months after recovery. The team then compared the scans of recovered patients to a non-randomized group of healthy volunteers and a group of risk factor matched controls. About 2/3 of the patients in this study were COVID patients who recovered from home and 1/3 recovered in the hospital. Now, the first thing to know about the study is that this was a non-randomized comparison. It's a small number of patients, and no one, that I know of at least, has collected CMR data on recovered patients with other viral or flu-like illnesses. The main top-line findings were 1, that left ventricular ejection fraction was lower LV volume and LV mass higher in COVID patients versus risk factor matched controls. Now, I'm not going to talk about the normal volunteer groups as they don't seem to be a relevant control group. The problem here is that the left ventricular ejection fraction in COVID patients was calculated at 56% and 61% in RF match controls. Now, the p-value may be highly significant, but is that really a clinically significant finding? I don't think so. The second major finding of this study was that 78 of 100 patients recently recovered from COVID had an abnormal CMR. Now, this included raised myocardial native T1 time, raised myocardial native T2, myocardial late gadolinium enhancement in 32 patients, and pericardial enhancement in about 22. But again, what exactly does that mean? The authors explain that increased native T1 measures represent diffuse myocardial fibrosis and or edema, whereas native T2 is more specific for edema. Venk Murthy, a cardiologist and imaging expert, wrote to me that T1 and T2 are tissue properties that may approximate measures of fibrosis and edema, but he emphasized that this was an approximation. Heart failure cardiologist Will Watson wrote on Twitter that T1 and T2 are the times taken for hydrogen ions in chunks of tissue to give back all their radiofrequency energy after you hit them with an RF pulse in the scanner. Now, if that chunk of tissue's hydrogen ion is made up of a different chemical, say a fat rather than water, they will relax at different rates. And then the MRI images produce contrast by giving different T1 and T2 values next to each other. In a map, you can quantify the exact time of each pixel's T1 or T2. Will Watson said, MRI researchers love this because you can get pretty colorful pictures. Now, someday we may have to refer again to native T1 and T2, so there you go, it's my 2 seconds on these measures. In addition, another key limitation of the study was that many of these CMR features and lab values have overlap with the risk factor matched controls. The authors' conclusions were that MR revealed cardiac involvement in 78% and ongoing myocardial inflammation in 60 patients, independent of the pre-existing conditions and severity and overall course of the initial COVID. These findings indicate the need for ongoing investigation of the long-term cardiovascular consequences of COVID-19. Well, that sounds scary, doesn't it? But the problems I highlighted above, the limitations I talked about, are only the tip of the iceberg. On Twitter, Daryl Francis and Graham Cole found numerous problems with the presentation of the data. In the transcript of the show notes, I will give a link to Professor Francis's thread. But it looks like the authors have substituted median and IQRs for mean and some other range. Now, this sounds technical, but it is a problem because, remember, CRP, high sensitivity troponin, and BNP, these are not normally distributed values. In other words, it's very common to have a value of, say, 2 to 3 times higher with a troponin or BNP, but your weight or height will not just double. Height and weight can be described with means, but BNP and high sensitivity troponin are not like that. Professor Francis specifically wrote not to jump to malfeasance conclusions, but these aberrations, once he points them out, are pretty obvious. And then his colleague, Dr. Graham Cole, points out that the patient they showed in Figure 1 had a high sensitivity troponin of 17.8, but he went to the plot of all of the high sensitivity troponins in Figure 2. That 17.8 high sensitivity troponin is not there. Now, perhaps this is just a typo. So, of course, we know that COVID-19, like any other viral illness, can affect the heart. But this study really needs to be interpreted with tons of caution. If you were cynical, I am not, but let's say you were, you could see how a cynic would find publication of a scary study, however flawed, weeks before decisions on what to open in society quite peculiar. Maybe a less controversial conclusion and final comment on this study would be this. Once again, public and open peer review have trounced the insular peer review of experts in the journals. Third topic, AF ablation safety. I'll start with a mundane statement, but it's important. AF ablation is a very common EP procedure. Gazillions of these things are getting done worldwide. One of the biggest concerns of this procedure, however, is thermal damage to the esophagus, which sits precariously close to the posterior wall of the left atrium. Now, thermal damage is a bit of a euphemism. Really, if you have enough thermal damage to the esophagus from left atrial ablation, you can develop atrial-esophageal fistula, which is fatal in the vast majority of cases. Now, the first challenge in understanding the safety issue is the mathematics. Well, the odds of having an esophageal injury during ablation are very, very small, well less than 1% likely. The consequence of having it, a fatality, are huge. Now, this is what mathematician Nassim Taleb writes about in the Fat Tales of High Risk, the asymmetry of risk. It actually came up in the Michael Jordan documentary that I'm watching. A young Michael Jordan fractured his foot. The doctor said, "Rest it. Let it heal." But Michael Jordan wanted to play. So he asked the odds of problems if he came back too early. The doc said it was 10%. And Michael Jordan said, "Great, that's a 90% chance of no trouble." Then the owner of the team asked the really important question, "Well, what happens if you're in the 10%? The doc said, "It's a career ender." So it goes with esophageal protection during AF ablation. Everyone who does AF ablation worries about this risk. At the virtual European Heart Rhythm Association, a group from the UK tested an already approved cooling device. The cooling device is used in cardiac arrest patients. They use this for esophageal protection. The idea is if RF heating damages the esophagus, then cooling from inside the esophagus may limit the damage. The device, which is called an ENSO ETM, is a single-use silicone tube. It's inserted into the esophagus similar to a standard gastric tube, but it has a closed-loop system into and out of which water circulates from a console. The St. George's group used an RCT, randomized controlled trial design, with 120 patients, half on standard care, half with cooling. Now, esophageal injury is very, very rare, so they had to use a surrogate endpoint, which is post-procedure endoscopy evidence of thermal injury, and they graded the injury on a 0 to 6 scale based on how the ulcers looked in the esophagus. Now, sadly, but not surprisingly, 30% of both already small groups dropped out after refusing to have the later endoscopies. Now, their preliminary results looked pretty decent. At 7 days, 93% of the protected group, the cooled group, had no significant esophageal abnormality, compared with 70% of the control group. Any degree of mucosal injury occurred in 3.3% of protected patients and in 20% of control patients. And there was a trend toward a lower incidence of gastroparesis among the protected group, but it was just a trend. Now, I highlight the study because esophageal protection is a hot topic. The positives here are that this device is already approved, and unlike some other esophageal protection devices, it seems pretty well non-traumatic. That said, this is a non-published study. It's small, there was significant dropout, and overall it's pretty inconclusive, but I think worthy of further study. Final topic today is that another SGLT2 inhibition drug has hit the cardiac radar screen. Now, in a press release, we learned that the Emperor Reduced Outcomes trial of empagliflozin 10 milligrams daily versus placebo in patients with heart failure with reduced ejection fraction, with or without diabetes, met its primary endpoint. And this was time to first CV death or heart failure hospitalization. Of course, this was a large multi-center trial sponsored by BI, and it will be presented at the European Society of Cardiology coming up in August. There were about 3,700 patients enrolled, and it will be followed for approximately 3 to 4 years. The press release gave no specifics on the effect sizes. Now, this is now the second SGLT2 inhibitor drug out for heart failure. Recall that dapagliflozin earned FDA labeling in May of 2020 after the DAPA heart failure trial showed a highly significant 26% reduction in CV death or heart failure hospitalization and a 17% reduction in all-cause death. We'll have to see the effect sizes of EMPA versus DAPA, but this category of medicines looks to be another advance in cardiac therapeutics. Before I close, I want to make an announcement. Next week is Mandrola family holiday, so this week in cardiology we'll take a week off and I'll resume the week after that. As always, I'm grateful that you listened. Thank you. And remember, if you like this podcast, please remember to tell a friend. Take the time to give us a rating or write a review. It goes a long way to help others find us. Until 2 weeks, this is John Mandrola from the Heart.org Medscape Cardiology.
You're listening to This Week in Cardiology from the Heart.org on Medscape.